on mind, I'm really excited. We've got two real eminent speakers with us. So something different we're doing now on Healing Our Earth. We've actually got two speakers together, two really proud and a pleasure to introduce two real experts in their field. And I'm going to introduce them both together, Dr. Bharat Pankania and Lord Jitesh Gadhia. So Gadhia, Lord Jitesh Gadhia. Jitesh, my apologies. Really, you can watch the interaction between the two of them to share some ideas as well. So with that, I'd like to just introduce both of them. So starting with Dr. Bharat Pankania, who is a passion for mine, a public health doctor. So you think, well, what's a public health doctor? So you think of people going down the sea and are troubling, and you've got these great emergency people rescuing these people from the sea, and that's all great. But actually, you've got some wise people going back and thinking, why are these people actually falling into the sea in the first place? And that's actually what a public health doctor would see. We see these people dying of a heart attack or COVID or whatever, but actually the real clever people will be looking back and seeing what are the themes, and they're looking at the next 5 or 10 years ahead. So with that in mind, Dr. Pankania, I hope I've given you an appropriate introduction to say that. And having worked in public health myself, I'm really interested. So Dr. Pankania, just to give you a bit of his background, really advises nationally on communicable diseases control at a national and international level, and is a senior consultant in communicable disease. He has done a lot of work in looking back at outbreaks such as the pandemic flu, influenza, SARS, Ebola, and I think appears actually on national television as and commenting on national guidelines. He does some very interesting work in looking back, a major plan of testing exercises, web-based surveillance. So do look up, even go to our website, healingourearth.com, and do read his background as well, because it's a real pleasure, Dr. Bharat, to have you with us. And along with you then, we've got Lord Jitesh Gadhia. Many of you know, so Lord Gadhia was actually on our inaugural session. We did, the whole Healing Our Earth started, as you know, with a global Gayatri mantra. And on that day, I remember we were there together actually with Lord Gadhia, who shared a really inspirational speech and spoke at that time of what was happening. And that was 3 months ago. So it's great to have you back on. Jitesh, have you been on since, or this is your second time on?
No, this is my second time, and I'm looking forward to it.
Fantastic. And I think last time you had this really inspirational Orm background, and this time you've got your study behind you, so that's great. So again, those not knowing Lord Gadhia really is in the theme and in the field of finance, a real expert in that field, is an investment banker, a businessman, and a member of the House of Lords, and really a board member of UK government investments, and really advising the UK government on various aspects of finance. Lord Gadhia serves on the boards of various companies. Please do read up his write-up really, and has been involved in some very prestigious companies, etc. Graduated from Cambridge University and attended the London Business School. So those are sort of the backgrounds. What we envisage now, I think, with Dr. Pankania and Lord Gadhia is an interaction between the two of you. We've got an hour together. We've just gone past, well, it's about 3:15 UK time. We've got the next hour together. So please use your time. Let us explore together the theme of COVID, whether it be from an economic, from a public health point of view, wherever you want to go. So I'll hand over to both of you, whoever wants to take off first, and let's enjoy and learn from your expertise.
Well, thank you, Milan, for those kind introductions. Namaste again. Good afternoon and welcome to this live broadcast, which I'm delighted to be co-hosting with Dr. Bharat Pankania, who, as you heard, is a world-leading expert on infectious diseases. Some viewers may have watched a session which we recorded together in mid-March, just before the lockdown, and it's great to be reunited to provide another update on the pandemic as we emerge on the other side of lockdown. If anything, we should have done this sooner. So welcome, Dr. Pankania.
Namaste everyone, and thank you for inviting me. What is interesting in your welcome introduction, Lord Gadhia, is we were ahead of the curve. So when we met in March, we were ahead. We could see the rising tide of problems to come. and look at how our world has changed. We're going to have a conversation, and in that conversation, I hope I can link in all the journeys we've made since we met at our home in March. And I just feel I feel pained. I feel a lot of pain that, considering we were well ahead of the curve in March discussing these matters at our home here in Bath, things haven't gone quite as I would have liked them to go. Let's have the conversation.
Indeed, and I think I would like to follow up many of the points you made. And indeed, you know, when we recorded the earlier video, you did kindly host us at your delightful home in Bath. And over the course of the last few months, many of the viewers will have seen or heard Dr. Gadhia on a regular basis on multiple TV channels and radio programs, sometimes standing in his beautiful garden, and at other times from indoors like you see today, with a wonderful brass statue of Nataraj in the background. Bharat, can I, before we do move on to the substance, can I just begin by commending you, not just for the sheer stamina you have shown, but also for the clarity of your public health messages, and also for the other selfless activities you do alongside, including distributing Gujarati vegetarian meals to those less fortunate in your local area during the weekends. Everything you are doing is a unique and genuine service to society, and I applaud you on behalf of the whole community.
Thank you. Thank you. I didn't know that you knew that I have been cooking my Gujarati vegetarian food. There's a hidden agenda here, Lord Gadhia. My hidden agenda is, apart from the seva, and I want the poor people, and Bath, a affluent city, has got poor people. I want the poor people to enjoy the best of Gujarati food, because Gujarati food is not Indian food in restaurants. So it has really been my pleasure every weekend to cook a different Gujarati vegetarian food and distribute it to the poor people here in Bath. It really has been a pleasure.
Well, that's a really noble mission. So when we met at your home on the 15th of March, the UK had almost 1,400 confirmed cases. And at that point, we had recorded less than 50 deaths from COVID. In the ensuing 17 weeks, we now stand at over 65,000 excess deaths, according to the Office of National Statistics. And we have registered the second highest deaths per million of population in the world. And as you said, it's a human tragedy which has touched so many families. So I think the very first point is to express our sincere condolences to those who have lost loved ones. We know the BAME, the Black, Asian, minority ethnic communities, including the British Indian community, has been disproportionately impacted, and we will specifically come on to that important topic. And as you also said, many of the themes we discussed in March have survived the test of time, and we were ahead of the curve in many ways. So perhaps today we can revisit some of those issues, but also look forward to how we live with COVID for the foreseeable future. It's clear that it's going to be an endurance test, a marathon and not a sprint. So I've identified 9 themes. So let's kick off with the first and discuss what we have learned about transmission and immunity since March, and maybe begin with the role of droplets and aerosol transmission, and what that means about being in confined and crowded spaces, and indeed the importance of ventilation.
Yeah, thank you. Very important subject. So we've had the line that this is droplet spread. And by droplet spread, we meant droplets coming out from your nose and mouth, heavy droplets coming out, landing on the floor and contaminating surfaces. So the root of infection was a direct hit from myself having a conversation with you if I were infected, and my droplets as a spray coming out and hitting you on the face, nose, mouth, and infecting you that way, or I contaminate a surface and your hands touch that surface, and then you introduce your hands to your nose and mouth and get infected that way. So that has been the majority belief. Having said that, in my introduction, I was introduced by Dr. Shah as somebody who does blue sky thinking. So I think the unthinkable. I think about what else could be the matter. And I've always been one of those awkward guys, shall we say, awkward in a nice way. I'm always thinking of what if it goes wrong? So I proposed and I said it about March when we were talking about the Diamond Princess docked in Yokohama Harbor in Japan. I said so on BBC News Channel that I think there is an additional mode of transmission going on here in this confined space. And I said, we have an issue about crowded places and a confined space and air conditioning and sewage systems, and we need to look into it. And very interestingly, about 5 days ago, the WHO said, we think that there is an additional mode of transmission as well, an aerosol mode. We knew for a long time that the tiny droplets, which probably don't have a lot of virus in it, remain airborne for up to 3 hours, especially in a confined space where there's a lot of people. So I believe that in a confined environment, there may be at play 3 elements of virus transmission. 1, the direct heavy droplets, face-to-face conversation. 2, the contaminated surface. And 3, possibly, maybe, to some extent, an additional factor, aerosol transmission. And what I mean by that is these tiny droplets travel a lot further than the 2 meters safety distance that we've all got accustomed to. So where do we go from here? Well, if this is fact and it is scientifically verified, we need to take additional measures in confined places where aerosol transmission may also be at play. What are these additional measures that we can take? The additional measures would be limit the number of people. So more people equals greater dangers. So we've had offices, workplaces, pubs, clubs, etc., all limiting the number of people. I would want to say we develop a formula for reducing that further or keeping it to a minimum. So limit number of people. Second point, you continue with all your normal hand hygiene and infection control, which is 2 meter separation, etc. Then finally, one more, very important. You either open your windows and you have thorough ventilation from both sides. So here in my house, by the way, this is my mandir room and my study is over there. So here in my mandir room, what I would do if I was sitting here is open the windows here, open that door here, and have a thorough flow of air. So people, please, everyone listening to me, in your homes, I've only tweeted this afternoon before coming on that we need other attention, such as increased ventilation in the workplace and in your homes. So I think those are the measures that we should implement immediately. Social distancing, hand washing every 2 hours, and ventilation. I'll come on to the subject of masks in a later conversation, if I may.
Absolutely. And maybe I can sort of link into that by just mentioning an emerging area of research which is related to what you've just described, which is sort of so-called super spreading, where one person infects a disproportionate number of other people, and the related issues of sort of super spreading events or venues ranging from meat packing plants to choirs, dormitories, nightclubs, food markets, cruise ships, I think you mentioned, and even a sort of Zumba classes in places like Japan or South Korea. And there's an obvious link here to crowded spaces and the sort of activities that give rise to droplets and aerosol. So maybe I can use that as a further link into addressing the use of face masks or face coverings, and where there has been now more evidence, and I think even you've said that you have changed your stance on this. It would be great if we could sort of summarize what you think are the current benefits, when to use them, what types of mask or face covering to use, and how to use them.
So thank you. So yes, leading neatly onto face coverings or face masks. So what is the purpose of these things? We want to catch the droplets. So if I were infectious, I want to release as few a number of droplets as is possible. So that's the purpose of wearing a mask. That infectious person, and we will talk about symptomatic and asymptomatic infectious persons later. So bank that for a moment, please. So I, the infectious person, will be releasing lots and lots of viruses through my nose, through my mouth. And the more I speak, the louder I speak, the singing, the choir, all those places, loud place. So you have to raise your voice to be heard. All those areas release more droplets. So what we want to do is have a face covering, and with a face covering, you are limiting the number of droplets coming out. It's not fail-safe. It is not an absolute protection. It is a relative protection. And the relative protection is you're reducing the number of droplets coming out of an infectious mouth. And the idea is this: I wear a mask, you wear a mask. I don't infect you, you don't infect me. And that's what we should do. So finally, where should we be wearing our masks? Well, if you understand the science, the biology of this virus, it is humans that infect you. So if you are out for a long walk in the countryside, in the park, away from other human beings, no need whatsoever to wear a mask. Why would you? No humans near you. On the other hand, if you are on a crowded train, a bus, a crowded supermarket, mingling with other people in close proximity over a prolonged period of time, I would wear a mask. And remember, the mask is not 100% protection. It is just reducing it a little bit. How much it reduces by, we don't know. Nobody's done these studies. So empirically speaking, common sense tells us, and the Japanese, the South Korean, and the Chinese experience tells us that wearing a mask reduces the level of virus, reduces the chances of getting infected. It's not absolute reduction. And we do it in crowded places.
That's very clear, and particularly I think the emphasis on, I protect you, you protect me, which I think is a very important principle of reciprocity. I just wanted to, on face masks, cover one or two other dimensions, because I think given the likelihood, and I hope this happens, that we make it much clearer that face masks or covering should be used in other places like shops, which obviously is very much in the news today. What types of mask should people use? And I think, and you've commented on this publicly, I think that there is a point here that we should probably just point out to people that don't use ones that have valves, and if you could explain that. And of course, for you wear a very elegant pair of spectacles, but obviously there is, for those who wear glasses, the issue of misting up, and if there are any tips you could provide just to alleviate that.
Lord Gadhia, I'm very impressed that you know a lot of my public announcements that I have made. I'm very impressed. Thank you for following what I have been saying in public. I'm very impressed.
Well, I
So,
follow you on Twitter, so and actually I think at the end we will just remind you of what your Twitter handle is, because I would definitely urge everybody to add you because it's always very informative.
thank you. So, with regard to masks, we don't want to wear surgical quality masks. We must not wear clinical masks at all. You wear a covering, and the best coverings are, if you're going to make it, and a lot of our people are very good at sewing and stitching. So please use your artistic license to make beautiful, colorful, interesting, picturesque masks. Let us showcase to the world the talent we have in our community. Go for it. So what would you use as a fabric? On the outside, you want it to be a tight weave, water repellent type fabric. On the inside, so it's usually 3 layers we want. On the very inside layer, you want it to be absorbent. So it is absorbing the secretions from your mouth. It's going to get stale, it's going to get smelly, etc. So you don't want it so absorbent that you cannot reuse it by washing it. So not too absorbent, but as absorbent as you can get away with regular washing. And then also a middle layer, which would be an absorbent layer. So 3 layers, make it nice and colorful on the outside, and it covers your nose and mouth area, just this area here. That is all you're after. Second point, this thing of the mask and the warm air coming up and hitting your glasses and misting up. Headache, absolute headache. So when I did surgery, that was really a headache. So what we did then was work out a system, and it is individual. So what we did was hold the mask there and then put a bit of sellotape there to stop the hot air from your breath going up and misting your glasses, and it goes down and out, or out over the sides. So that's the procedure I would use. I know it is not a perfect solution, but you're not wearing a mask all the time. You're only wearing it in crowded places. So a bit of sellotape may help.
I think those are great tips, and I think as we increase the prevalence of wearing a face mask, I think those will be really valuable. Now, you mentioned asymptomatic transmission. There's more research coming out on that. It seems that anything between 40 to 80% of infections occur from individuals without symptoms. Can you just summarize for us what we now know about this and what the implications are?
Yes, thank you. So our viewers, our listeners may be aware that in 2002, 2003, a new virus emerged, and we called it the SARS virus, severe acute respiratory syndrome. It is part of the coronavirus family, and the SARS-CoV-2 that we are dealing with today is related to the SARS that arrived in 2002, 2003. The reason why I'm dwelling on this is as follows. When you got the infection with the SARS virus, 2002, 2003 version, you became infected and symptomatic. In other words, you showed signs and symptoms of illness, high temperature, unwell, short of breath, clearly ill. And at that point, when you became ill, you were also infectious. So illness and infectiousness came at the same time. So as soon as we knew somebody had a temperature and they were ill, we were able to pull them out of circulation and pull all their contacts out of circulation. So that was luck on our side. We were able to identify the cases, pull them out, identify their contacts by contact tracing, pull them out. And that public health action plus a bit of good luck helped us eliminate SARS from planet Earth. Now, coming on to the coronavirus COVID-2 that we're dealing with today, unfortunately, it is smarter. The GTI version, or the souped up version of this virus, is a lot smarter. And the smartness is people are without symptom infectious. So you could be perfectly normal, like me, like you, like others, perfectly normal. 80%, up to 80% of the people are perfectly normal, but they are throwing out these viruses through their mouth and nose. So they are infectious without symptoms. This is very serious, because therefore the mental picture in people's mind is, I am okay. I can't possibly be infectious. Therefore, what's the big deal about infection control measures? What's the big deal about being close to you? What's the big deal about shaking hands? And so on. So you can be without symptoms, infectious. Makes control very difficult. So we need to treat, and I made a headlines on this line. Again, March the 7th, we were ahead of the curve. March the 7th, in the Sun newspaper of all the papers, I said, treat everything and everyone as infectious. If you treat everyone and everything as infectious, irrespective of any signs and symptoms, you will be in a better place. So my advice of 7th of March still stands. Everyone and everything, every place, treat as infectious. These are people without symptoms, but are infectious. I hope that answered your question, Lord Gadhia.
Yeah, very, very much. And look, I think that important principle also has knock-on impacts on other areas, and we'll come on to the whole issue of testing and tracing later on. But obviously, this is a fundamental issue affecting that. If we could maybe round off this first point, first area of discussion around just immunity. Who has it and how long does it last? We've had more seroprevalence surveys released, which estimate the number of people within a country who have been infected with COVID by testing for antibodies. And the interesting thing is that apart from big cities like London or New York, where anything up to 20% may have been infected, it seems like most countries, and I saw a survey released from Spain recently, that most countries taken as a whole don't have infection rates of much more than 5%, which means that the vast majority of the population is still vulnerable. And I assume we will really only know more about how long immunity lasts with the passage of time, given the sort of recency of this virus. But some of the Chinese studies from Wuhan seem to show that it could fade quite quickly. However, and this is where I want to sort of bring you in, we do have some more encouraging evidence around T-cell response or cellular immunity. And look, we have viewers with a wide spectrum of different scientific understanding. So maybe you can explain this in layperson's terms. What do we know about immunity, and what are the at least the encouraging signs that are emerging from this?
Yes, thank you. So this is some positive news that we have, and I'm going to take you through the journey. It's a lovely journey. The common cold virus is part of the coronavirus family. So we have MERS in the Middle East Respiratory Syndrome. We had SARS, and then we've got SARS-CoV, and we've got the common cold virus, all brothers and sisters, one family. Okay, and you all know that you often get a cold about every 6 months. So the implication there is that when you've got your cold, you don't make long-lasting immunity. So you catch it every 6 months, and hence your common cold recurs. That is because the coronavirus, for whatever reason, doesn't induce memory. So it doesn't induce immune memory to make the body recognize it when it appears a second time. So the idea of recognizing a second time is immunity. So your B cells, these are the ones, your B cell chain, these are the ones that recognize you. They make memory. They recognize you and then they say, I've seen you before. And then they make antibodies against you and attack you as quickly as possible. So your B cell memory cells are your watch, your guards. They see, they spot you, and then they raise the alarm, and then they make antibodies, and the antibodies come and neutralize you and eliminate you. Job done. And coronavirus doesn't seem to make immune memory with the beta cells, the beta white blood cells. Now the good news bit, okay? The good news bit is we have found that it makes cellular immunity. So that's really good. So it down the T cell line, it makes cellular immunity. So why aren't we out celebrating now? The reason why we're not out celebrating is that the T cell response is a bit sluggish. So the virus arrives, it starts doing its destructive work on you, etc. Then the T cells are activated, and then they come and they tackle the virus. But T cell, the war with T cells is sluggish. It's slow, it's not instantaneous, and it's not immediate. So the T cell line of defense is sluggish, is the best description I can give you. But the good news is that in view of the fact that we are making T cell memory, could it be that when you have a second infection, that your chances of not having a severe infection are better, are improved? Time will tell. So there is good news, and we hope that it prevents you from getting a severe infection a second time. Time will tell. Now, I'm not going to go on to the vaccines bit just yet, because I want to keep your interest. We will talk about the vaccines and immunity and B cells and T cells soon.
Absolutely, we will most certainly come on to vaccines and the therapeutic area as well. It's one of the 9 themes. So second, and before we sort of look more forward, I just wanted to turn, and I think we couldn't not turn to care homes. There have been more than 20,000 deaths in these settings. It's a real, I think, stain on all of us. Dr. Pankania, what went wrong and what lessons can we learn?
Yes, thank you. This is very sad. I feel very sad about it. And you will notice by my Nataraj and my Buddha, when I do these media interviews, I symbolically light a candle. The camera may not pick it up, but I light that symbolic candle in sympathy, in pain, in remorse, in shame, that the United Kingdom, the country that we are, a clever country, clever scientists, we made a mistake. It's a terrible mistake that we made. So there was a pressure, there was that panic, you could say. In Gujarati, we would say, sukarsu, right? We've got a problem here. So the panic was, we've got all these cases rising, we need hospital beds. So we, and I mean Labour governments and Conservative governments over the last 20 years have systematically reduced bed numbers per population, per head of population. So for a rich, affluent country, we have reduced bed numbers by a huge margin. We are acting as if we are a poor nation with regards to bed capacity. What to do? What to do? Pandemic has arrived, bed capacity, nothing. So we thought we'll send all these old people home. We will send them home under a bit of duress to the nursing homes and the residential homes, that you will take these people. So that decision was made, and these people were taken from the hospital to the nursing home, the residential homes. And there was a failing. The failing was, it is a failing. Don't let anyone tell you, but Saib, I didn't know. It's a failing. Admit it, repent, and move on. So the failing was, when you move a potentially infected older person to the nursing home is not a clinical setting. The nursing home is managed by people, many on minimum wage. They work in many homes to make ends meet and that sort of scenario. Nursing homes are not, despite the pay that you pay them to keep your elderly parents there, they're not run as well as they can be. And many of them are not even financially viable. So it's not like they're raking in the money. It's just the way it is. So people got into the nursing homes, they passed the infection from person to person, and a lot of people, a staggering number, over 20,000 in the UK died in nursing homes as a result of a basic error. The basic error was we introduced an infectious agent into a vulnerable environment, and then in that vulnerable environment, the infection spread like wildfire, and that's the result. We should look into this. We should never make this mistake again. It's very sad.
Look, I think we're totally agreed on this point. I think, if there is going to be any silver lining out of this human tragedy, I think deep reform of our social care sector should definitely be very much high up on the list. So look, let's look forward a little bit. So that my third topic is really, learning to live with COVID, and I've already mentioned that the battle against this disease is an endurance test for all of us. With new cases rising globally, there's a continued need for vigilance and not letting our guard down. And I wanted to sort of explore how we do that and live with COVID. So, Bharat, I know you have been concerned around the risks of reopening prematurely, given the current level and rate of infections, and to remind our viewers, it's currently estimated to average 14,000 people within the community in England alone, according to the latest Office for National Statistics numbers. And whilst that number has been falling and is on average 1 in 3,900 individuals, it's still significant if you compare, for example, to Scotland, which yesterday reported 7 new cases and 0 deaths. Whilst you can't eradicate COVID completely, you can try to eliminate it. So what are the lessons, particularly from Scotland, Dr. Gadhia?
Yeah, that's a lovely question, and this is a very important question. I hope our listeners are going to pay attention to this, because this is, as my introduction said, forward thinking, going forward, planning, and what do we do about this matter. So let me start. I said at the beginning, when this started to happen, to the media, and remember, I've got 2 minutes in which to get my message across. So for me to slip it in is a monumental achievement, and it's not always that I manage to slip it in. So this is what I wish to slip in, and I have slipped in when good people, BBC Radio 4 is very good, very good. They're sharp presenters. I salute them, I really do. They are the best. So BBC Radio 4, thank you. She gave me a little opening and I went for it. If you do not look after your country and the poor country at the same time, it will come to bite you. That's the shortest message I can give you. So with regards to the virus and the virus in presence around the world, we've got to eradicate and eliminate it. And we do that in our country, and we do that in the poorer country at the same time. Because if you do not eradicate it in Kenya, in Africa, in Brazil, India, Malaysia, Indonesia, poorer countries. What is fermenting over there, amplifying by a number of people because they are populous countries, then what happens there comes to bite you here. That is the problem. So if you look at the New Zealand model, it is fantastic. Please go and look at the New Zealand model. They did something that we need to salute them, and their premier, she has done a marvelous job of saying, we are going to adopt an elimination strategy. So they were hard and fast on testing, contact tracing, and border control. And as a result, New Zealand has had very few deaths. And once Australia, which is also following a similar model, think about it, Australia and New Zealand can be one bubble. United Kingdom is an island. We can also control our borders. And as a result of controlling our borders strictly and setting aside political economic considerations by inventing bridges, ain't gonna work. You should be as strict as you wish to be, as you can be. And if you are really strict, you can eliminate it. The political will has to be there. So you do extensive testing, extensive contact tracing, and secure your borders so that you control it in your country. So my final line on this particular subject is, I'm saying it, and I'm saying it here first. Hear me out. This virus, to all intents and purposes, is going to become endemic. And what I mean by that is it's going to be here for a long time. It's going to be part and parcel of something we have to live with. We will have to live with it. It's going to become endemic. And as a result of it becoming endemic, we will just have to be careful. We will have to hope and pray. We will talk about vaccines and medications later, but we are going to have to change the way we live. Maybe on this particular platform here today, it's a good thing in that we will heal the world. So there's a lot of healing to do. Maybe we will heal because of the coronavirus. Watch this step.
So look, that's a brilliant segue into the next and the fourth area I wanted to address, which is how do we control the virus going forward, you know, almost with or without, but hopefully with an elimination strategy. And central to this is making the testing and contact tracing system effective. It's clear that it's still a work in progress. And I wanted to sort of put 3 points to you, linking some of our earlier conversations. So the testing aspect, given the asymptomatic incidents that you referred to earlier, it seems that we're compelled to do more randomized testing. Otherwise, we won't know who is impacted and where those people are. For contact tracing, this capability needs to be more, I would say, localized. And I would like to turn to the question of Leicester in a moment, but certainly at the moment, we don't also have an app which creates a gap in the coverage. And the third point is clearly we need public cooperation and trust if we are going to get people to take the measures necessary, particularly to self-isolate. Have I summed it up in the right way? And where would you add and amplify those points?
Yes. So recently on one of the media outlets, I could see the presenter saying, this Pankhanyak Sahib is always moaning. He said, how many more tests do you want? And I said, listen, we are testing. Numbers are large, but they're not large enough. Let me expand. Lord Gadhia has touched on it beautifully, really. He's said it absolutely right. He's on the ball. He is, honestly. So what I'm getting at is we have selective testing. You order a test, it comes in the post, and we don't know. We don't know how good are the home tests. No idea. So people, do a swab. Do you think they're going to do it properly? I don't think so. It's a very uncomfortable thing to do at home. Shove it all the way to the back of your nose. It ain't working. So then the other one is you go to a place, usually out of town, you drive to it and you get your swab test done that way. Now, all those are a selective population. What Lord Gadhia was absolutely right in referring to is we need to have localized testing, locally delivered, locally accessible. And when you have your GP practices that we all know where our GPs are, and you could have them testing it, or you could have dedicated staff stationed at your GP practice, set up a little booth and have your tests there. And also in shopping centers and places like that, there you are picking up the true signals. So you test randomly, you test extensively, you test all the population, not only the population who can drive and get tested. I hope I've made my point clear. So having done that random extensive testing locally with local results immediately, you identify the positives. And having identified the positives, you say to them, sir, out, 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 get out of circulation immediately. And then we open up the contact tracing branch and we say, all the contacts of that case, out, 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 get out of circulation. And this sounds like a complicated thing to do. Believe me, it isn't. I'm a master of contact tracing. When I say I did all of this, but when I say I also mean my GP colleagues, my genitourinary medicine colleagues, my public health medicine colleague, my public health colleagues, my environmental health officers. We are all local experts. We do contact tracing every day. Why are you not using us? Why, on the other hand, have you got somebody following an algorithm to follow steps of contact tracing, paying them 10 quid an hour? They're not as good as I am, my colleagues, me and my colleagues. So we should do contact tracing locally by locally run experts. We can supervise the people that we employ. And if you think this is too difficult, I don't think so. Because when we had the pandemic swine flu outbreak, 2008-ish period, we did exactly this locally. So it was the Health Protection Agency then, and we tested extensively with sending of swabs. We processed the results and got them the next day, and we contact traced from home, from the local area. So it can be done. We'll talk about Leicester in a minute. I've got some interesting things to share with you about Leicester.
Well, actually, why don't we go to that? And as we know, it is a city which has recorded the highest levels of infection in the UK. And certainly, as we all know, because we all have links into it one way or the other, there's a big South Asian community, around half the population. And in the northeast quadrant of Leicester, which has the highest concentrations of South Asians probably in the whole of the UK, we know that's the epicenter of the outbreak. What are your reflections on the sort of this whole issue of local data, the infrastructure and the empowerment? Because look, as we saw in today's Sunday Observer, there's another 20 locations which are on the list for potential lockdown. So we really have to learn the lessons of Leicester so that we can address those in other places as required.
So this is a fundamental of outbreak control and management. I would teach my children, my students, and it is lecture number 1, really. So the fundamental is, if you know, you act fast. If you don't know, you don't know. Then you act late. If you act late, you have an outbreak, you end up with a lockdown of the whole city. So with Leicester going into lockdown equals failure. You failed, 0 out of 10. Let me expand on this a little bit more. So if you are testing locally, you will know the rising tide of cases coming your way. And you will also know that it is sector A, sector B, sector C. It's factory A, factory B, school A, whatever. But if you are testing locally with local demography, in other words, you do simple, easy things like capture the person's postcode, for goodness sake. So the central testing has not been capturing the postcode of the tests. And it is a selective number of tests, as we've alluded to before. So you need to have testing, and you need to have the results locally. Of course, you share them with the government nationally, but the results should be available to the local outbreak managers, the incident commanders locally, as well as centrally at the same time. But you need to have the data locally in a timely manner. So for you, the mayor of Leicester, to say, I didn't know I had a problem until tier 2, pillar 2 data results were given to me centrally, is a failing. We should not be in a position where you get a phone call from headquarters in London telling you you've got too many cases. You should know about your cases. You should know the nature of the cases and stamp it out. So the analogy is, you have a forest, it's dry, it is prone to fires, and you need your surveillance systems, your spotter, to identify where the hotspots are occurring. So be it in North Evington, Melbourne Road, Spinney Hill Park, all those areas of Leicester where you're getting hotspots. You go to the hotspot, so you will already know the values, the behaviors, the nature of what may be going on in that hotspot, and you stop it. And if you stop it, you won't have to shut down the whole city. So early action, early timely action, early intelligence locally allows early local actions. And then you don't have to have a lockdown.
That's very powerful, Bharat. I wanted to next move on, which is in some ways related, but in some ways much broader, which is the impact of COVID on the Black, Asian, and minority ethnic communities in the UK. We first really got the real data on this from the number of people going into ICU, although actually for those who had sort of had their antennae up and open, it was visible even earlier on. And you know, I remember noting this when you know, one of the first major nationwide alerts was at Northwick Park Hospital in Harrow, which is located in the heart of a large Asian community in northwest London. And if you look at the COVID deaths by ethnicity, and you know, you will have pored over them, it's really quite a stark picture. So for South Asians, something between 2.5 to 3.5 times more likely to die from COVID, with the highest risk category being Bangladeshi and Pakistani men. And you know, you can, you know, there are some known factors, and I'm sure you'll go into that, but you know, we know that there are at least 3 factors. One is the comorbidities, so things like diabetes and heart disease. There's the social and cultural factors, particularly the high number of multi-generational households. And then there are, if you like, the socio-demographic, the types of occupations held by Asians make themselves more vulnerable. You know, 30% of medical staff are Asian, and 44% of NHS staff are BME. So that gives you, you know, a clear explanatory factor. But even if you seem to remove all of these explanatory factors, there's still an unexplained difference. And so it would be really interesting to get your take on this, whether there is any genetic factor, and indeed then linking that to, back to some of our homes in, South Asia, or for people in Africa or the Caribbean, there doesn't seem to be as much incidence at the moment, and I would stress at the moment there. So how do you sort of put this conundrum and pattern together?
Yes, thank you. It's such a delicate and important topic. And what it is highlighting is poverty kills. So we have known for a long time that poverty kills. And we have our Black, Asian, ethnic minority groups. And a lot of them, we have very, very successful BAME people as well. But we also have a lot of them in poverty. And when you have crowded homes, when you have poor accommodation, when you have multi-generational dwellings together, there's nothing wrong with it. Absolutely nothing wrong. Live with your mom and dad and your grandparents. I would advocate it. It is a good thing to do. Don't give it up. It's just a reflection of poverty. Okay, so poor people also have poor jobs. So the poor person living in a poor household, multi-generational household, will also be the bus driver. They will also be front line in a healthcare setting, the cleaner, the washer, the taxi driver, the restaurant person, the restaurant waiter, and they have a greater chance of getting hit by an infectious person, or it's a bit like Russian roulette. If you carry on playing Russian roulette, eventually there will be a live bullet in the spin of the revolver. So it's similar to that. Repeated exposures, and one of those exposure eventually finds you. There's one or two items here which I'm pretty sure about, so I'd like to stamp on that. I think there isn't a genetic component to this. I feel we shouldn't go into this genetic area because there are nefarious people out there who wish to make us separate from other fellow human beings when we are not. We are all fellow human beings, all of us, all races, all cultures. And I don't think there is a genetic component. But what I am interested in, and I haven't got an answer, we haven't got an answer, is could there be deficiencies of certain things like vitamin D? My answer is, I don't know, we don't know. Could there be other deficiencies? We don't know, I don't know. What we do know is we do have a lot of diabetes, heart disease, high blood pressure, and all of those add to our burdens of being severely ill were we to get infected. We are prone to diabetes, and we are prone to heart disease and blood pressure, especially Africans. Africans have a huge propensity to high blood pressure. And so all of those people, plus poverty, makes them into the vulnerable group. So what I have advised, what I am advocating is we know what we know. We can't just sit here and say we don't know everything, therefore we can't do everything. My advice is, in view of the fact that we know these people are vulnerable, where you can, please make other arrangements for them. So remove them from frontline patient-facing consultations in a hospital setting, for example. If you are a bus driver, give him, her extra protection with maybe better masks, better PPE, and maybe a less crowded bus. So do something for these people who are driving your buses and running your hospitals and are frontline and are at risk. So you can do a risk assessment for all people, not only BAME, all people. And if you identify that they are at higher risk, do something about it. I hope that answers your question.
It does, and I think you make a very important point that there's a limit on how continually we can dig into the explanatory factors. And I think we have probably identified at least the contours of most of them already. And some of them, frankly, we already knew about because there were existing healthcare inequalities or other inequalities that existed. And actually now is time for action, and we do need to take those precautionary measures, as you say, whether it's vitamin D or additional PPE or other risk-based steps to reduce the exposure of these communities. So thank you for highlighting that. I wanted to move on to remaining on the sort of theme of community, some community-specific issues, and in particular, things like family gatherings, weddings, where they have been permitted to be resumed, but with no more than 30 people allowed. And then also cultural and religious festivals. Obviously, places of worship have now been permitted, obviously under certain guidance, to be reopened. We have Raksha Bandhan coming up on the 3rd of August and Janmashtami on the 11th and 12th of August. I know you've been very helpful, and interview in March had some of these points, but could you just reiterate for us and give us your advice, particularly with these festivals coming up, what actions, precautions we should take?
Yes, thank you. So this is easy, really. It's my bread and butter. And the easy bit is know the biology and the science of infection. So coronavirus spreads by droplets and contaminated surfaces and maybe an aerosol element as well. Learn that, remember that, act on it. You've got the solution. So think for yourselves, and you now know droplets, dirty surfaces, introducing it to your nose and mouth, and in a crowded place, aerosol spread as well. So what you would do is you say to yourself, I look after you, you look after me, we look after everyone. So you're going to have your gatherings, good, have them. Be careful. If you can have them outdoors in the summer months, better. If you can have them in a more open space, better. If you can have them in a hall, and you tell the people, Sukariya, it's going to be a little bit cold. We've got to have the windows open. Checks and balances. So we've got to have the windows open. We're going to have good, thorough ventilation. We're going to even have machinery to have a good flow of air, and let us remain safe during this auspicious gathering. Of course, wear your masks as well and wash your hands. Now, with regards to wash your hands, you timetable it. So you say every 2 hours, you're going to wash your hands. And that is a good thing to do. Wash and dry. It's not only wash your hands. And when you just cannot wash your hands, you can use the alcohol gel on otherwise clean hands. So basically, the answers are, you already know them. You stay away from humans as much as you can, and you remain clean. If you cannot remain away from humans at gatherings, for example, Janmashtami coming up, you all want to go to the Krishna Mandir, then you have to understand that numbers into the dwelling will be limited. One of my colleagues' fathers died at the Krishna Mandir, having caught coronavirus disease, infection, and then disease, and he died. So this isn't a joke. This is serious. Few numbers, good ventilation, good hygiene, and we hope for the best.
Indeed, and frankly, I think I would say that a lot of the community organizations, the temples, the gurudwaras, darasas, etc., are using Zoom and sort of webinars, and I would frankly continue to encourage them to, as much as possible, use those mediums as well, because I think large gatherings, as we've heard, is not actually a good idea. They can be super spreading events. So we haven't got that much time left. I'm sure that with the help of the organizers, we will have a little bit more than, maybe we'll be able to extend.
Don't worry, Jitesh, Lord Gadhia, yes. We're really enjoying it. Please do carry on at the moment.
Okay, well, we'll try and wrap it up by 4:30, because I wouldn't want to stand up my my noble friend Lord Ranger. So what we'll do is we will speed it up, but there are four other topics I wanted to quickly cover.
Please do carry on. Maybe you could just at least just bullet point the themes coming up, but the things coming through on social media, on WhatsApp, everyone is really enjoying this session and is crediting both of you for the clarity of questioning and the clarity of answering. So please do continue.
We'll try and stick to that. So the next question was really around air travel. We did cover this partly with the speaker before, and the whole question of holidays and quarantine, particularly as a lot of people, will be contemplating what they do in July and August. Some will have cancelled their plans. Others may not have been able to receive a refund. And some might just be tempted to have a change of scene, but are hesitating about, flying away. What's your honest view on this, Dr. Pankania?
Simple, very simple. So, you know a lot about what I do. Maybe you don't know a lot about my inner soul that drives me. And my inner soul that drives me is peace and tranquility on planet Earth. And we have trashed planet Earth. So please, if you can, reduce your carbon footprint. Do your seva to planet Earth. Don't fly. Give it a break. And it will protect planet Earth. It will protect you. And give it a go. The United Kingdom is a beautiful country. For 2020, give it a miss. Don't fly.
Well, look, I wholeheartedly agree with you on that. I think if there was ever to be a year for staycations, this is it. I've also cancelled my own plans. I think others, I think I read today in today's papers that the Prime Minister and the Chancellor are also doing staycations. So I think that is the way to go. Next, I wanted to ask you a very direct question. Is a second wave inevitable and just a matter of time, or can we prevent it?
Yes, thank you. And I will be fast with all my answers. So I don't want anyone to think of these as waves. I don't want you to think of the Spanish flu 1918 pandemic. This is slightly different. So there are no waves. This is a continuation of the wave. The wave has gone up and has gone down because we went into lockdown. And when we start mingling, and we are starting to mingle in the summer months, I don't expect the case numbers to shoot up because we will be doing outdoor activities. Outdoor activities, the beach, the park, the picnics, the cycling, the river paths, etc., are low risk activities. But I am concerned. I'm concerned about autumn. So autumn, September, October, November time, when schools open, etc., I am very concerned at that time. One piece of advice which I may give at this point in time, please, to everyone, whether you need it or not, get your influenza vaccine in September. All of you, everyone. It's only £10 if you're not entitled to it. Do it. It's good for you.
I'm pleased you made that latter point. And in fact, I was going to raise it with you if you hadn't. And indeed, I very much hope that there will be some further announcements by the Department of Health and Social Care, by the NHS on this topic. I think clearly, if there was ever a year where everyone should take their flu jab, this is most certainly it. And we don't fully understand what the interaction is of flu and coronavirus. There's been some research which I've read into that as to whether or not it sort of amplifies each other, but just the thought of it doesn't sound very, very helpful or encouraging. So I think that's a very important nudge, which I hope we will get more of and more news about as we go into late summer and early autumn. So the next area, and we trailed this before, is around therapeutics and vaccines. So on therapeutics, we've made some encouraging progress and validated through clinical trials the use of drugs like dexamethasone, a steroid which cuts the risk of death for those on ventilators by a third, whilst I think some others like remdesivir, which is an antiretroviral, are probably a little bit more disappointing, especially given the high cost. What are your current views on the available therapeutics, and are there other promising drugs on the horizon for treatment?
So thank you. So Ram, let's deal with dexamethasone first. With respect to dexamethasone, as you said, it saves some lives, some small number, those people who are severely ill, needing oxygen support or ventilatory support. So it's some lives. With respect to remdesivir, a lot of you clever people out there, go and read the proper research on remdesivir and dig around a little bit, dig around, do a little bit of work. I think remdesivir is not good, and it has found its way, and the United States and the White House has bought up supplies. There's something not right there. I'm not convinced about remdesivir. End of story. There are no other drugs on the market that we know are of therapeutic benefit. Please do not go around using your azithromycin, azithromycin, that's the antifungal drug, or your hydroxychloroquine, your anti-malarial drug. No evidence. So we have, unfortunately, at the moment, no drugs. Dexamethasone is of some benefit. I'm not convinced about remdesivir and how it found its way into being used by the United States, care of the White House.
That's very clear. So if we could maybe turn to the prospects and timing for a vaccine. I think there are something like 200 different vaccine initiatives underway around the world, with a dozen or so in human clinical trials. And what would be maybe quite interesting is to get your perspective on it, and particularly from what I understand, there's quite a possibility that if and when we do have a vaccine, and it takes time to do these, the earliest I've seen it heard from credible sources is for the second half of next year. Even then, it will be sterilizing immunity. It won't be sterilizing immunity, i.e. that it stops you from all time from having COVID. But maybe it might, for a short-lived period, a bit like the influenza vaccines that we have been talking about, where you need maybe an annual jab or a booster. What are your thoughts on vaccines?
Yes, okay. So the reason why we have the annual flu vaccine, the seasonal influenza vaccine, is because the seasonal influenza virus expresses different proteins every year. So these are the H and the N, the hemagglutinin and the neuroamidase. These are the proteins against which we make the seasonal influenza vaccine. There's about 9 or so different types of H proteins and 12 or so N proteins against which they keep on changing every year. So we make the vaccine against them. Now then, coronavirus vaccine, a completely different cup of tea, completely. So we know the target protein, that's the protein that latches on to the ACE receptor in humans. So this is the ACE receptor in humans, and the protein comes and it makes beautiful fit, and then it infects you. So we will be making protein vaccines against that protein, maybe other proteins as well. The problem is immune memory. For some reason, the beta cells don't seem to make memory against a coronavirus protein. There will be clever people out there working on tricking the human body into making memory against a coronavirus protein. And that will be a marvelous breakthrough if we succeed. My advice is don't put all your eggs in the vaccine basket, because we may never make one. So remember, with HIV virus, we never made a vaccine. So let us see. Only time will tell.
I think that's a salutary message. I think we should definitely plan to live with COVID. And if we get a vaccine, clearly that will be upside, if you like, and a bonus. But we shouldn't certainly plan on that basis. So finally, I wanted to end on the importance of public trust in health messaging. And, you know, if nothing else, the last several months have demonstrated how crucial it is to take timely decisions and action when it comes to public health, but also to communicate things in a clear fashion. And sometimes I think we have suffered from mixed messaging, and whether that's on sort of 2 meters versus 1 meter, face coverings are mandatory or not, work from home or go to work, use of public transport, which is a new emerging theme that is coming up, and sometimes the complexity of messaging. So I certainly get a lot of questions, even from my own family, about, you know, what is all of this stuff about bubbles and who can meet indoors and outdoors. It's a complex web. What is your feeling about having guidance versus rules versus making these legal? Can we legalize common sense?
Yeah, so I learned something very important from my dear friend. He is still a professor at Imperial University. And my friend Azim said to me, when I asked him, how do you write all these papers? He said, keep it simple. Say it as it is. So Professor Azim Majid, I salute you. You taught me something really important. And the important bit is keep it simple. So our messages should be succinct, simple, and understandable. And it has to be consistent. We cannot have our chief medical officer saying between the lines, be careful, the virus has not gone away. And then we have our ministers and prime minister saying, go out and have a drink in the pub. I think the message from the prime minister should be something like this. I know you're going to go to the pub, but first and foremost, be careful, be very careful, be very, very careful if you're going to go out and have a drink in the pub. It's that order of say it, but mean it, and be succinct, be simple, be straightforward, be consistent. But overall, bottom line, communication skills are very important. Keep the message simple. So here in the West, the Southwest, where I gave weekly broadcasts on BBC Radio, BBC Points West television, I developed a strapline, which was keep away from humans. And that was so successful, you know, easy to understand, easy to remember, keep away from humans. We need those messages repeated consistently.
Dr. Bankania, that is, as ever, in your own style, a great way to end. I totally agree with you that, in a way, greater health confidence will boost economic prospects, and they're not a simple trade-off. As always, it's been a pleasure interacting with you. I'm truly grateful for your clear and comprehensive answers to a very wide range of themes and questions. Whilst we have discovered a fair amount about COVID, we are still learning more on a daily basis about dealing with this health emergency. So I'm sure we will continue to call on your expertise. Thank you once again for everything you do. And as someone who believes in the power of human resilience and ingenuity, I'm confident that ultimately we will emerge from this crisis stronger and wiser. So until the next time, namaste, and please keep well.
Thank you. And if you wish to follow me, then I put as much updates as I do on my Twitter handle, which is at Dr. Saib, DoctorShaib. come and join me. Come and do the journey with me. It will be good. Take care. Namaste.
Thank you.
Namaste, and thank you so much to both of you for such an informative session. The last hour has flown by, where in fact it's been over an hour, and through social media and other ways there's been lots of positive feedback. One to Lord Gadhia for some very succinct themes, and we went through a whole journey from infection control to how to manage as the public. So Jitesh, thank you. I'm sure you've had some BBC Radio 4 training, I'm sure, in there as well. Although you didn't grill anyone, but you did really well. So thank you so much for coming back on. And, you know, real words of gratitude to Dr. Pankania, your clarity, your expertise, and sharing those messages. And the human side of you, the cooking you're doing, you shared about your love for the planet as well, not to trout, you know, all those things. So we've really enjoyed this last hour, myself as well, even being a medic, having learnt so much, and being a GP, I actually sat in my room, in my consulting room, having done some video consults. And yeah, we're preparing ourselves also for the flu campaign. So those of you, please do come for your flu vaccination if GPs around the country are planning of how we might do that in a safe way. But we covered so much. There have been some burning questions. I know it is actually 4:30. We have Lord Rami Ranger with us. Lord Ranger, I can see you there. Please do bear with us just for a minute or two. One question that's been coming through. So welcome. You can see Lord Ranger there on your screens, who's going to be our next speaker literally in a minute or two. One question did come through about antibody testing. A lot of people have been asking. There are a lot of various places that are offering antibody testing, and what your view on it, because even as people come to me and say, dear doctor, shall I go for an antibody test? Very quickly, what your thoughts were about that?
So antibody test is best done with taking a blood sample rather than a capillary sample. In other words, you take a volume of blood rather than a finger prick. Okay, that's a more precise result. Second thing, the only thing that an antibody test tells you is you have survived a coronavirus COVID-2 infection. That is all it tells you, that you've had an infection, whether you knew about it or did not know about it, and no more, no less. It doesn't tell you that 6 months down the road, you're going to be immune or not. That we don't know.
Exactly, and I think that's the key message to others as well about that. And another theme which comes in quite nicely with what Lord Ranger is going to come across, which is the economy. And Lord Gadhia might bring you in as well. This theme of encouraging the economy, people to go out and go back into shops, get everything going, eat out to help out, and all these things are going on as well. So we've got this mixed balance between trying to get our economy going, support local businesses, and at the same time trying to keep ourselves safe. And it's a real juxtaposition we find, you know, the government trying to encourage us as well. And I don't know if you've got any thoughts on, we want to, you know, boost the economy, but at the same time, we also, there is, you know, understandable fear and, you know, lack of confidence.
There is a balancing act, but as I said, I think in some of my concluding remarks, we should be careful about a sort of a false trade-off, a false binary, if I can put it that way. Improving public health actually will help our economic prospects. And Dr. Pankania referred to the example of New Zealand, right? In New Zealand, you can see that New Zealand is booming because they've got this, pandemic under total control. Now, obviously, there is a risk, and they've had to face the risk of people traveling into the country and bringing it in, but they have now a very strict regime and method of being able to address that. And so really what I would say is that, there is we can manage health and the economy together, and we've got to do it together and in lockstep if we want to get the best results.
Excellent. Thank you, Lord Gadhia and Dr. Pankania. Again, in a moment, I'm going to actually welcome one of a key member of the Healing Our Earth team, which is Nitin Palan, who was actually on earlier, who's come back on. So Nitin Bhai, I can see you're online in a moment. Just to actually, I know you've got a connection with both of these speakers and to thank them as well. So I can see you online. Please do just also just share your thoughts.
Could not thank you guys enough. So clear, so succinct. What we learned in the last 4 months, we learned in an hour and a half. So thanks very much indeed. This hour and a quarter should go viral to every human person on this planet Earth. This is more clear than what ministers talk about, wise men talk about. And I'm not saying this because I love you both dearly. This was really highly professional. Thank you very much.
Thank you.
So be ready. I think those of you who are watching at home, that this particular, I think all sessions have been really good. So don't single out anyone or particularly good. And we will, I think we will see a clip of this certainly being shared, on websites, etc. So those of you who are watching at home, please do tell people to still go on to Healing Our Earth. You can watch it from the beginning. Do rewind back an hour and a quarter and watch this session. So so with that, a big thank you to Dr. Pankania and Lord Gadhia. Dr. Pankania, I think I'm going to come round and sample some of your Gujarati dishes.
You must.
And see what's on offer. I tried to say stay away from humans, but my spouse wasn't having any of it. So.
I was treated to a fabulous lunch by Dr. Pankania and his wonderful wife when I visited his home in March. So it's well worth doing, Milan.
Good. Well, I hope you picked up the recipes, or I'll come round to you instead and try from you.
We welcome everyone. We are proper Indians, and we welcome everyone.
Good. Well, thanks to both of you. So we carry on. So those of you who are watching at home, I really enjoyed that session. Being, even from a medical background, I picked up so much. As doctors, we're talking all the time and sharing things, but it was really nicely done. So I'm sure those of you at home really enjoyed that session, and there was a really nice chemistry between the two of them, and a real clarity of sessions. But we carry on. So do look on healingourEarth.com.